pyramidal tract down to the level of the spinal cord. The second neuron starts within the spinal cord and leaves to synapse with a muscle. We would call that first neuron an upper motor neuron. Its axons are carried by pyramidal tracts. We would call that second neuron that originates from the spinal cord and gives rise to an axon that extends all the way to the muscle. We would call that a lower motor neuron. So again, somatic motor pathways are two neuron pathways. They're composed of an upper motor neuron and a lower motor neuron. And in fact, knowledge of this two neuron pathway is the basis of clinical neurology. If somebody has a stroke within the cerebral cortex, does that represent damage to upper motor neurons or lower motor neurons? Upper, yeah. On the other hand, if somebody has a herniated disc that's compressing a spinal nerve, well, that represents damage to lower motor neurons. Okay? And the importance is this, is that in either case, whether you have a herniated disc or you have a stroke, you can have motor weakness. But the clinical presentation is going to be different depending upon whether the damage exists at the level of the upper or the lower motor neuron. If someone, for instance, has an upper motor neuron lesion, they may have right upper extremity weakness, but it's going to be spastic paralysis, where they can't move the upper extremity, but there's increased tone or spasticity in that arm. In addition, the reflexes, for instance, the biceps reflex, is going to be hyperactive. Like that. On the other hand, if someone has a lower motor neuron lesion, they may have weakness in the same extremity, but it's going to be a flaccid weakness, where the arm perhaps just hangs, and the tone is decreased. If you did deep tendon reflexes, in this case, instead of being hyperactive, they would be hypoactive. You'd see less of a reflex response. So when we evaluate patients with weakness, a good neurologist, the first thing he's trying to determine is whether this is upper or lower motor neuron disease. And it's based on this idea that somatic motor pathways are two neuron pathways. Everybody follow me? That's kind of fun.
Yeah, for the most part.
How does Bell's palsy happen?
Oh, it's a virus that
Okay.
infects the subcranial nerve.
Okay.
But would that be upper or lower motor neuron? If it involves the seventh cranial nerve, a nerve is in the peripheral nervous system, that would be a lower motor neuron lesion.
Yeah.
Now, let's go back. We're talking about motor areas, and here we demonstrated the primary motor cortex, which is labeled area number 4. Just anterior to it, also within the frontal lobe, is area number 6, which is called the premotor cortex. The premotor cortex. Okay? It says the premotor cortex is the memory bank for skilled activities like playing piano or typing. In fact, as we learn a new skill, we program the premotor cortex to send impulses in the proper order to the primary motor cortex so that our hands move according to design. Okay. In other words, let's suppose, anybody here has ever played piano? Okay. So, when you're first learning to play the piano, you may be playing note by note. You're going to look up at your sheet music and you say, oh, that's a C. I'm going to move my thumb, okay, and press down on middle C. Then you see the next note maybe is E, and I'll take my middle finger and press down on the E key. And maybe the next note then I'll look up is G. Maybe I'll take my fifth finger and press down on the G key. Okay? Well, and I can go through the entire piece that way. Once I do it a dozen times, I no longer have to look up at each note in sequence. That information has become ingrained or programmed into the premotor cortex, so that once I press down on that first note, the C, everything follows by memory. It's like the memory is on autopilot. It's programmed into the premotor cortex so that once I press on the first key, then the correct sequences are moving to the proper area of the primary motor cortex to initiate the correct sequence of muscle movements. And whether you're playing piano, or you're dancing, or you're writing your signature. When you write your signature, you may think about that first letter, but then the rest of the letters kind of follow automatically. Or think about when you tie your shoe. It may be a long time since you've learned how to tie your shoes, but when you first learn, you learn, okay, you make a rabbit ear here and maybe a rabbit ear here, and then you kind of twist them over each other and then pull, and you think about each step. By the time you reach the age of 21, you no longer have to think about each step, do you?
I'm not 21 yet, so I guess I don't know.
Well, I'm giving you a vision into the future. Your fingers are going to move automatically.
Gotcha.
Okay? You're going to find that things you had to think about before, your fingers are just moving magically. Okay? Because that information is programmed into the premotor cortex.
Yeah, I'm a baby. I'm not 21 yet.
Okay, that's all right.
It's like texting.
Oh, yeah.
The more you text, like, the less you have to look.
Unless you wrap your car around a pole.
Now,
I didn't wrap my car around a pole. That pole went flying.
let's try to control ourselves. I'm going to point out a third motor area. Okay, if we come below the premotor cortex down to the inferior aspect of the frontal lobe here, this area here, 44-45, is called Broca's area. It's an area that's important for the expression of language. Now, before I talk about Broca's area, let me say this, is that there are two language centers. One called Broca's area for expression. The other one's called Wernicke's area for reception of language.
Like comprehension.
Comprehension. Okay? These language centers tend to be located on the dominant lobe. I'm sorry, the dominant hemisphere. In fact, the dominant hemisphere is defined as that hemisphere that houses the language centers, Broca's area and Wernicke's area. Most of us, not all of us, are left hemispheric dominant. That means that the language centers are located within the left hemisphere. Some of us are right hemispheric dominant, and some of us have codominant hemispheres.
Could you know that from MRI, or would you have to die?
You could learn that not from MRI, but from other studies like PET scans,
Okay.
okay, and evoked responses. You could learn that.
Okay.
Others more sophisticated studies.
Okay.
Okay. So right now, let's focus on Broca's area. So Broca's area is the motor speech area. Okay? It controls the muscles used in speech. It says that most people it's present only in the left hemisphere, and that's an example of left hemispheric dominance. Okay? Broca's area allows us to communicate our thoughts to other people. Okay? Damage of this area of the brain, and most commonly the result of stroke, will result in what's called an expressive aphasia, or Broca's aphasia, which represents an inability to verbally express our thoughts. Okay? People with a Broca's aphasia, and you see this quite often, they become very frustrated. Okay? They can understand everything you're saying to them, they simply have difficulty responding back. So if I'm Mr. Jones and I come into the emergency room and someone says, "How are you doing today, Mr. Jones?" or "What brings you into the ER, Mr. Jones?" They'll go and say something like, my car. They can make sounds and sometimes words or even parts of phrases, but ultimately they can't express themselves articulately. And so if anything does come out, it's usually something deep-seated, and oftentimes it's an expletive. So they'll get very frustrated. They'll say, "Fuck! Goodness sakes!" I said, "Goodness sakes." So they become extremely frustrated. Okay?
I know.
Is there a way to know whether someone is,
I like your dress.
I don't know, the severity of the stroke, if they're still able to understand, or is it just by those types of expressions?
Oh, that's easy to determine if someone can understand and communicate. That's what we do all the time.
Okay, I guess
So if I ask you, for instance, Emily, what brought you to the hospital, okay, and you can't respond appropriately, I know you're having trouble with communication,
right.
okay? Or if you give me some other answer unrelated to the question, then I know you have a receptive aphasia. Okay, you can communicate, but you can't understand what I'm asking you.
Yeah. I guess I was just curious because I used to care for this boy who can't verbalize, right? And I've always wondered if he could understand. Like, is there any kind of test that, like, obviously this isn't what we're talking about. I get that. Like, is there any way of
So what do we
knowing
do
what he
in
understands?
an ER setting with someone who has Broca's aphasia? Many times, we can still communicate with them using a whiteboard. If the stroke isn't too dense, they can continue to communicate in verbal form. Now, if it's a very dense stroke to Broca's area, they lose that function as well.
So they can write.
They can write or they can use pictures to communicate. But if it's a really dense stroke, then sometimes not even that. Yes.
My uncle has Parkinson's,
Yes.
and he can understand everything we're saying, but a lot of times he can't verbalize, like almost like you said, except he doesn't get really frustrated with it. He kind of stays calm, and if you're conversing with him, you also have to stay calm.
Yeah, Parkinson's is a neurodegenerative disease of
Yeah.
the basal nuclei,
Mm-hmm.
but as it advances, it can involve other parts of the brain.
Okay.
Abby, you?
Yeah, so I was just gonna ask, like, because there's different types of aphasias. Are those in different areas? Like, when you think you're saying one word, but you really saying another one?
Yeah,
Like,
there's.
do you know what you're meaning to say?
There
but
are
you
different
can't
types of
say?
communication disorders. For instance, there's anomia, which is a difficulty in word finding. And speech therapists are aware of a wide variety of subtle differences. So in a sense, these are all forms of aphasia. Okay, but usually I'm talking about a Broca's aphasia is fairly easy to recognize simply because the patient can't say the things they need to say. But are there subtler forms that are less easily recognized? Yeah.
Well, so, like, are those types of aphasias in Broca's area, or are they somewhere else?
They're usually around those areas because Broca's area, well, let me say this. They're going to be around the language centers. They're going to be somewhere around one or two. They're going to be around the language centers. There's 2 language centers. And we'll talk about Wernicke's area. And these language centers, for instance, the Wernicke's area is close to the primary auditory cortex where we pick up sound. It relays that information to Wernicke's area. So it's got to be within those areas that contain the pathways for language. So they're either going to be around Broca's area or around Wernicke's area. Because those are the circuits that are involved in speech. What do you call it if someone has damage to both Broca's and Wernicke's area? So they have difficulty both with expression and reception. Well, it's not bilateral because it's still unilateral, but it would be called a global aphasia. A global aphasia. Now, I watched this movie the other day. It was called something like Still Alice.
Oh, a whole bunch
that
of
movie.
awards.
Yeah, it was a really good, and it starred Julianne Moore. Julia Moore, is that her name?
Yeah.
Yeah.
Okay, and so she was a lady, she was a linguistics expert whose whole occupation, she had an academic career devoted to linguistics. But she was becoming what? She was developing what?
Alzheimer's.
Alzheimer's. And so one of the first things to go was she had word finding difficulty. She had anomia, so she'd be in the middle of a speech and she'd look for a word, but she couldn't grasp it. Okay? Well, that's a form of aphasia. It's not the type we typically associate with Broca's or Wernicke's, but it's a type of difficulty with language.
Can aphasia be affected by lack of sleep?
Well, you know, in general, cognitive function
Yeah.
in general can be affected by lack of sleep. Okay? You know that, for instance, if you do EEGs on patients, okay, who are prone to have seizures, lack of sleep can trigger seizure activity. You know, we call that a sleep-deprived EEG. So yeah, lack of sleep can affect cerebral function. So the term aphasia means an inability to use or comprehend words. And expressive aphasia is an inability to properly articulate and vocalize thoughts, whereas a receptive aphasia is an inability to comprehend spoken and or written words. Now let me ask you a question. If somebody came in, let me show you this here. This should make sense to you. This is a lateral view of the brain here. Okay. And let's say here's the central sulcus. And so this area here is going to be the primary motor cortex. And down here is going to be Broca's area. Okay? Okay? Now, the vessel that provides blood flow to both the primary motor cortex and Broca's area is called the middle cerebral artery. Okay? In some patients, the middle cerebral artery will come up like this and start to branch like this. If you had a little cerebral thrombosis that blocked the middle cerebral artery at that branch point, then it could potentially affect both the language area here, Broca's area, and the primary motor cortex. So it's not uncommon that someone who comes in with a Broca's aphasia